Good late afternoon and early evening, everybody. My name is Jerry Sachs, and I'm probably going to be one of the unique speakers to present to you because I have very little scientific background. My last official scientific endeavor was in organic chemistry as a freshman, and I did spend 10 years as a retirement job at the National Museum of Natural History. But I come to you today because I'm a former patient. I am a current patient here at the NIH, and I've been a patient here longer than some of you have been alive. I've had an interesting journey. Started patient here for 36 years. I had melanoma, after which they discovered some thyroid cancer, had 2 surgeries, some therapeutic doses of 100 millicurie of I-131. They discovered my PSA was going through the roof with readings over 22, close to 23, and after 20 biopsies, they said you'll probably die with the disease, but not of it. So it's really my privilege and to share with you my experiences and to give you some of my observations and suggestions as coming from the patient's perspective. I'm really standing in for a woman by the name of Susan Butler, who for 9 years gave this presentation. Susan was diagnosed with breast and ovarian cancer and died in 2010. And in your manual, I guess, your principles and practice of clinical research, I recommend, heartily suggest that you read chapter 13, Susan's chapter on clinical research, a patient's perspective. I think it's a must-read for you. Obviously, those of you who are here in the audience today know that the Clinical Center is a unique facility. It's been in operation for 60 years, and it's America's exclusive and premier research center. As I understand it, there are about 1,500 research studies going on at any one time, and we accommodate about 10,000 patients a year. And the last current one, of course, is our famous Ebola patient who is here getting treatment. So why do patients come to the NIH? Some come who are healthy. These are folks who come with a desire to help others by contributing to medical research and advancing science, and most importantly, to save lives. Some who are sick, some who may have been referred by outside private physicians, but you know that there are a lot of self-referrals these days, are those who have exhausted all options and come to take advantage of new treatments that are inaccessible in any other way, most of whom, or many of whom, come looking for a medical miracle. My thesis really revolves around the fact that you as researchers, you doing clinical research, need to establish a partnership, one that's based on trust and understanding, partnership of peers, one that advances medicine and ultimately saves lives. To be successful, your research in some measure will be dependent upon the cooperation of your patient volunteer. Their confidence in you will help to establish a positive relationship and one that can be extremely helpful to you and for the outcome of your study. At the very heart of this partnership for patient and you as scientists as well is the basic optimism and the deep hope for the future outcome for both. So while thinking about this, I created an acronym, something that is kind of general in the government these days, and I named it Q. Q for communication, understanding, and empathy. With regard to communication, verbal and nonverbal skills are critical. You have only one chance to make an initial impression, and as the principal investigator in all cases should be present. Take the time. Be thorough and make it in a private setting. Explain the role of fellows, which is kind of unique to those of us in the private sector. Don't push for an initial decision. Let people absorb what you're offering, what the protocol is all about, and give them time to consider it. Provide a full explanation of every aspect of how the process will work, and understand that patients can be intimidated and overwhelmed, especially during their initial meeting. Explain the impact, the risks, and the possible side effects while undergoing treatment. Will they be able to work? Will they be able to take care of their family? Will they be able to carry on their daily lives? What will be the duration of the trial? What's the frequency of visits? What are transportation issues and possible costs, if any? And should they bring caregiver with them? Never conduct this in the hallways or standing in the doorway of a busy clinic. Respect their privacy. Remember that sitting really connotes a sense of importance and a conversation of peers. Eye contact. A sense of direct engagement when they have your intention was when they see you looking directly at them. Listen intently. No writing or typing until after. Seems that there is a new concept of physicians typing while interviewing the patient, while talking to them. I have to tell you, personally, it's very off-putting. My strong suggestion to you is to maintain that eye contact, to maintain that rapport, and only after you're finished talking to the patient and getting their input, then put in your report, get to your computer and do what you want to do. Also, if you call me Jerry, I want to call you Joe. If you call me Mr. Sachs, then I should call you Dr. James. Remember that. Just a small little thought that really will keep your patient at ease. And I suggest that you review the patient's file in advance of coming into the meeting. I've been in too many meetings, too many clinical meetings when the physician has come in and sits down and then looks at the file and then looks at me. And I have a sense that they really haven't done much to study who I am, what I'm about, what has occurred to me prior to their coming in. And it's very important, I think, for you to consider that particular possibility. Think through in advance what questions your patient volunteer should ask. And if they don't ask them, those that you think are important, you tell them. You suggest what information you feel is important, even though they don't ask. Remember that particularly the first time, but not necessarily excluding all other future visits, that the experience here is intimidating and overwhelming, and give your patient volunteer the time to absorb the information that you're delivering. Encourage note-taking. Oftentimes, people are exercised and they're excited, and they may not really remember the important things that you want to convey. So encourage them to take notes while the meeting is going on. Be totally accessible between clinic visits. Oftentimes questions are going to be raised in people's minds and patients' minds after they leave you. Make sure that they know how to contact you, and be available, be accessible by phone or by email, and return calls and emails promptly. Again, it's off-putting if in fact somebody has a question that they feel is important and they don't hear from you for an extended period of time. And if a relationship warrants it, depending on the relationship that the patient has with their primary care physician back home, keep that physician informed as to developments. Understanding the U in Q. Remember that listening is more than a 9-letter word. Make sure that you assess the patient's volunteer's understanding of what you're trying to tell them. Do they really get it? And be careful of the overuse of medical jargon and translate. Make sure you translate technical terms. And respect for the patient volunteer's own research. In this day of the internet, you know, a patient who is really on the ball, or think they are going to go to the internet and start doing their own research. Sometimes that research, that information is going to be good, and sometimes it's not going to be valid. But don't disparage their attempt, and if they have in fact found something that is inappropriate, guide them to the right source. Be honestly optimistic. No false hope, but accentuate the positive while eliminating the negative. Understand that patients who come usually are treated in the private sector. And coming here, there's a very different atmosphere. The clinical research environment can be very different to them, and in some cases intimidating and off-putting. And recognize this and be sensitive to it. And make sure that patients understand that they can discontinue their participation in the trial at any time. It's their choice, without negative consequences to subsequent treatment. The E in Q is for empathy. Recognize that the clinical center is a large and complex facility, and particularly the entire initial experience and even subsequent visits can be intimidating and overwhelming. And ill patients can be exercised, emotional, and remember, for some, you represent their last hope. Time management. Don't be rushed. That's very off-putting when a physician comes in and says, well, I only have a minute. Who or what is more important than the patient sitting in front of you? Be on time. If you've attended clinics, you know that sometimes patients are made to wait an extraordinarily long period of time. That's disrespectful to the patient, and especially to someone who is sick and very anxious. Delivering bad news. Every patient is a very real and unique person with genuine fears and hopes, and not just an experiment in your lab. The diagnosis that can include the perception that life as one lived it, is at its end, over, gone forever, and that there may be little help for the future. Recognize the sensitivity of that. It may be a great stretch, but try to put yourself in the patient's shoes. It's important for you, in doing this, to give it your best shot. I understand what the patient is going through. The causes of cancellation can be that the trial has been canceled, the treatment has not been effective, severe or debilitating side effects are overwhelming, the patient is not complying. Whatever the reason is, it can be devastating to the patient. Make sure when you're delivering bad news, just as you do when in the clinical visits, that the appropriate setting is important. Make sure it's secure and quiet, and you can have an uninterrupted time with the patient. And I suggest that the principal investigator be present when delivering bad news. It's important to hear from the boss the reasons behind the discontinuance of the protocol. And make sure you, let me move along here. Make sure you allow the necessary time. Don't rush the presentation. This is such a critical, emotional, and sensitive time for a patient. Make sure you allocate the proper time. And in most cases, make sure the patient is not alone, that he or she has someone with them for support. Oftentimes, the patient will not really hear everything you're saying, and they're going to count on their companion to give them that information. Be careful with the language that you use. Words like "nothing more can be done" connotes hopelessness and abandonment. A complaint that some cancer survivors have voiced is the phrase that some physicians and others have used from time to time, quote, "You failed your chemo or another treatment." By most reasonable measures, the failure is not that of the treatment, is that of the treatment and not of the patient. And hearing the phrase utters contributes mightily to making bad news even worse. This type of pejorative type of language should never, ever be used. Have in your discussion, in preparing for the discussion, other possible options that may be available for the patient. Make sure that the patient is in this case, communicate in advance with the referring physician. Make sure when the patient gets home that he or she can have the advice and counsel of their primary physician, and so that the physician knows what has been going on with the process. So do take my cue. Make communication, understanding, and empathy cardinal elements of your partnership relationship with your patient volunteers. You know that the clinical center has been called the House of Hope. Susan Butler actually created that name. And I would like to add that the clinical center is also the community of caring, and that you are in this important and critical partnership, that each of you is the primary giver of that hope and care. Thank you. Are there any questions? Thank you again. Thanks for listening, and thanks for thinking of the other side of your experiment, of your protocols. It's critical for those of us who are on this side of the examining table. Thank you.
Well, good afternoon. My name is Kate Stoney. I'm here at NIH at the National Heart, Lung, and Blood Institute, And before he leaves, I want to thank Jerry for a really inspiring and wonderful talk. It really, I whispered to him on my way down that it set me up perfectly for some of the things that I want to talk to you about, so I appreciate it. So I'm going to talk to you about some of the things to think about when you are conducting clinical research in terms of the participants that you choose. And on the face of it, it might seem like a pretty straightforward kind of thing, but we're going to delve into some of the complexities here. And I want to start by saying that I'm deliberately using the word participant here instead of patient. And the reason for that is to, again, underscore one of the things that Jerry talked about, which was this collaborative partnership between patients and the researchers, the scientists. That collaborative partnership is really critical in all elements of your selection of your participants, all throughout your study. And so I like using the word participant to underscore that this is somebody who is working with you as a researcher, working with you to accomplish the goals of your particular study. And let me just also mention that if you have not looked at the video from Miriam Kelty, which is part of your assignment before tonight's talk, I encourage you to do so afterwards. She really talks about parts of this issue, participant selection, from a very different perspective, really critically important. So she talks about inclusionary factors, some ethical considerations. So this talk would not be complete without covering those elements. So please do look at her video fairly soon after, if you haven't already, fairly soon after this talk, so you can get a rounded picture of what we're talking about here. Okay, so there are a number of questions that you may think about when you are thinking about participants that you want to choose for your research study. And obviously, one of the first ones is, how do you choose? How do you decide who you're going to study? And on the face of it, sometimes people say, well, I'm a hypertension researcher, so I'm going to select participants who are hypertensive or at risk for hypertension. And that is part, but not all of the story about how you decide which participants to study. Another thing to think about is how generalizable the findings from your study will be, or do you wish them to be? Because that generalizability is going to be determined in part by the diversity of your participants. So that's a consideration, and we'll talk about all of these things a little bit more. A key element is to think about whether you're actually studying the participants that you want to study. Are the people that are in your study, do they have the characteristics that you want them to have? And in order to answer that question, you have to know what you want in your research participants. So another thing we'll talk about in a little bit. And then really critically, it's important that you match the characteristics of your participants in your study to the outcomes that you're interested in capturing. And we'll talk about why that's important in a minute. So those are sort of the outlines of what we're going to go through. So let's really think about some of the reasons that you do need to talk about and think about your participants. And one of the reasons that I like to think about right off the bat is that when you start really thinking about these issues, what are the characteristics of the people who you want to enroll your study, it really helps you clarify not only the question that you're asking, but the study design that you want to be using. And let me illustrate that with a graph. So you all know that when we conduct clinical trials, that all studies kind of fit along a continuum, a translational continuum. We think about phase 1 trials, very, very early stage trials, as being primarily for safety, for dose ranging, and those sorts of trials tend to enroll very, very small numbers of participants And generally, not always, but generally they're healthy participants. These are very small studies where we're trying to determine what the right dose is, whether it's a pharmacologic agent or a behavioral intervention. We're trying to find out how much somebody needs. And in particular, we're interested in safety issues. Okay. When we move to phase 2 studies, these are efficacy trials. And these are studies that are very tightly controlled. You maintain, as your researcher, a lot of control over the participant characteristics, over the characteristics of the intervention, over the characteristics of the environment. And you maintain that control because what you're looking for here is a signal for efficacy, right? You really want to know, is there something there? And in these studies, in phase 2 studies, we generally also have small, not as small as phase 1, but generally small numbers of participants, and they're very highly selected, because that's the name of the game in phase 2, you imposing lots of control. In phase 3 studies, these are effectiveness studies. And in phase 3 studies, we're really looking for less control on the part of the experimenter, right? And more looking towards running real-world types of studies. So for phase 3 studies, we tend to enroll lots of participants. We don't select them as carefully as we do with phase 2 trials because we're trying to look at these kinds of interventions in real-world settings. So we don't want to exclude a lot of people. And in phase 4 studies, and these are really community-based studies, they can be implementation studies, we're really looking for real-life situations. And there we have very little control over who is a participant in our study. So going back to what we started with here, when you think about who your participants are in the study, it makes you think about not only the questions that you're addressing, but also the designs that you want to use. And in order to do that, you really need to know where your study fits on this continuum. Okay? In order to know that, you have to know something about the literature in the area. So you need to know if phase 1 trials have already been done in order to know if you should be moving on to a phase 2 trial, an efficacy trial. You need to know if there's lots and lots of literature showing efficacy for the intervention that you're interested in. If so, your study may be ready for a phase 3 trial. And that brings us back to the participants that you're going to enroll in your study. Because if you're running a phase 3 trial, you're not going to have a lot of inclusionary and exclusionary criteria because you're not going to highly select your participants, right? You're going to be taking a lot of participants who are interested in being in the study because of the phase of the study that you're at, okay? If you're at a very early phase study, you're going to have very tight control over the characteristics of your participants. Okay, so that makes sense? It's a really important point. Okay. We also think it's really important to think about how generalizable your findings should be. And in order to think about generalizability, what we're really talking about is, do the findings that you get, the outcomes that you're looking at for the particular study that you're doing, can they generalize to a broader population other than the small sample that you're studying in your study? So this brings us to a brief discussion of internal and external validity, and I don't think you've covered that in this course yet, but you will when you talk about significance testing. And in significance testing, you'll talk about internal and external validity with respect to the analysis plan that you're going to propose. Here I'm talking about it more theoretically, okay? So I'm not going to talk about the analytic part, but I do want to talk about the importance of understanding where you want to put your validity, and more in internal validity or more in external validity. It's a balance, okay? When we talk about external validity, what we're really talking about is the extent to which you can generalize your findings. And if you have a study where you set the external validity high, that is, you really want to generalize your findings, what that means is that you're going to maximize your opportunity to generalize to a broader population, but at the same time, you have a risk of running an error. And the error that you're going to run is that you're going to get false positives. We call that a type 1 error, right? So a false positive simply says that you think you have a finding, a significant finding, but you really don't, okay? So what we've done is in increasing our external validity is that we have loosened up control, and because of that, we have a higher risk of type 1 error. So when we talk about control, we're talking about control in terms of the participants that you're selecting for your study, but also control in terms of the situation, how much control you have over the intervention that you're implementing in your study, the control over the time and place. When you loosen those things up, you're more able to see an effect, but you're also more likely to see an effect that's not really there. Okay. So on the other side of this balance beam is internal validity. When we talk about internal validity, we're talking about imposing lots and lots of control. And when we're talking about control, we're talking about the same things. We're talking about control over your participants, over your intervention, over the situation, over how things are done in your study. When we maximize that control, what we're doing is we're saying, I really want to be in control of all these factors. I want to decrease the variability due to error, due to things that I am not interested in. And I'm willing to do that even in the face of having a type 2 error. And a type 2 error is the opposite of a type 1 error. A type 2 error is the type of error that you have when you fail to see an effect that's really there. Okay? And that's what we sometimes talk about as a false negative. So these two things are in balance. And when you design your analytic plan, you have to make a decision about which of these things is more important to you, external validity or internal validity. And that decision depends on the particular question that you're asking, where it sits on that continuum, because I've already told you that in early stage research, we like to have lots of internal validity, lots of control. We loosen that up in later stage research and give more ability to generalize our findings. So you have to know that in order to know which kind of risk you're willing to take, the internal validity or the external validity. My point here is that if you have high external validity, where you're going to get a type 1 error, you also have a better ability to generalize your findings to a broader community. And that can be important depending on the question you're asking. This is what I just said. All right. Your participant selection factors that you select are going to impact the feasibility of your study, right? That's just common sense. The more factors that you impose on who you select, the more difficult it's going to be to find people that have those kind of characteristics. So you have to think about feasibility issues. And it's a very practical thing, but you really do have to think about feasibility issues when you consider the participants that you want to select. And let's talk about that for just a minute. You want to make sure that you have access to your participants that you're targeting. Okay, so you want to make sure that the characteristics that you're interested in are characteristics that are available in the population that's available to you to be a research participant. And that has to do with both clinical kinds of characteristics as well as demographic characteristics. You also need to consider for the characteristics of the participants that you're interested in, what the likelihood of participation is and what the likelihood of adherence to your protocol and adherence to your treatment is. So, for example, if you have a very complex intervention, very complex protocol, and you want to enroll 2-year-old children, the feasibility of actually completing that study successfully, because you have a very complex protocol and you have little kids that you're trying to enroll, is low. So it's something that you need to think about. There are ethical questions to consider, and again, Dr. Kelty's video goes through these in a very nice detail, and I encourage you to watch that video. But when you think about, can you randomize the particular participants that you're interested in studying, you need to think about not only can I randomize those participants to your active intervention arm, but also is it ethical to randomize them to your placebo arm? And this is a point that I think we sometimes miss when we think about characteristics of our participants. All of the kind of factors that you think about in relationship to your intervention arm, you also need to think about in relationship to your control arm or your placebo arm. And you also need to think about the timing of your intervention in relationship to feasibility. So if you're interested, so I'll just, disclosure here, I'm from the National Heart, Lung, and Blood Institute, so a lot of my examples are cardiovascular in nature. Okay. So let's say you want to do an intervention with individuals that have just had a heart attack, okay? And you want to get them within 12 hours of having the heart attack. You really need to think about the feasibility of doing that to determine whether it's really a study that can be successful. So thinking about those events that happen in real life before you actually enroll participants is really critical. So the outcomes that you select are going to be determined in part by the participants that you select. So here's what I mean by that. When you select, some of the outcomes that you might want to select are event outcomes. Everyone likes to measure events during their trials because we really want to know what the real clinical impact is of our intervention. So we want to have heart events. Heart events are morbidity, mortality, right? So heart attack, death, stroke, these are heart events. So those are one category of outcomes that you may be interested in. The problem with those events is that oftentimes you can't predict them, and they take a long time to occur. So they're not always feasible, right? So sometimes we set some surrogate markers for events. These are things that increase people's risk for whatever the ultimate event is that we're interested in, but they take a shorter period of time to actually occur, or they're easier to measure. So surrogate measures are things like, you know, again, a revascularization in somebody that has angina. That would be a surrogate marker for ultimate cardiovascular disease. Sometimes we're interested in patient-specific outcomes. In particular, we may be interested in patient-reported outcomes like symptoms. What kind of symptoms are you experiencing? How much pain do you have? These kinds of things can only be obtained, or most reasonably be obtained, from participants themselves. So if that's the target of your outcomes, that's the outcome that you're really interested in measuring, you need to make sure that your participants are able to report on that measure. And then we often will have a composite type of outcome that we're interested in, where we say, you know, our primary outcome is going to be a composite of a large number of outcomes. So when you think about the outcomes that you're interested in targeting, you need to make sure that they match with the characteristics of your patient. So let's give a couple of examples. One question to ask yourself is, are the targeted outcomes feasible? Can you measure them in the participants that you have selected? And what that means is, do they have a stage of a disease that makes them eligible for actually having the outcome that you're looking at? All right? So the example I gave here is a study measuring cardiovascular endpoints like heart attack, myocardial infarction, in healthy women who are 50 years old. Maybe they have a little bit of elevation in their blood pressure, but they're basically healthy. This would not be a feasible study, right? Because how long is it going to be before 50-year-old, basically healthy women have a heart attack? A really long time, 20 years, 25 years. So unless you want to follow these people for 25 years, and unless you can get funding to do that, this is not a feasible study for that outcome. So you may choose a different outcome if those are the patient characteristics that you want to study. If you want to study 50-year-old, essentially healthy women, then you wouldn't target MI as your outcome. You would target a surrogate measure or a patient-reported outcome or a biomarker, because those are more feasible to study and to see differences in a short period of time. You also want to think about whether your outcomes can change within the parameters of your trial, given the characteristics of the participants that you are enrolling. So the example here is if you're planning to measure a change in carotid artery IMT, right, over the course of 6 months, in a basically healthy population, you're not going to see differences because carotid IMT doesn't change very much, not in a measurable way, over 6 months in healthy people. It probably doesn't change reliably in not so healthy people. So again, think about the participants that you're enrolling in terms of the outcome that you're wanting to target. And then if you really are interested in patient-reported outcomes, you really want to think about whether your patients are able to report on the outcomes that you're interested in. And you know, again, the idea of asking a child to report on certain symptoms may be difficult. Not that children don't have those symptoms and they can't express them, but it's very difficult to get consistent data from a 2-year-old of any sort. The point in all of this is that the decisions that you make regarding the characteristics of the participants that you plan to study are going to influence your ability to make causal inferences. And that is what you want. You want to be able to make causal inferences. If you can't, then you don't have a successful study. Okay? So let's go through some of the characteristics of participants that you want to think about before you run your study. Okay, you have a general idea of what the intervention is or what the question is, and you probably have a general idea of who the participants are or who you want to study. But you want to lay out what your entry criteria are very early on. And those entry criteria include inclusionary criteria, who you're going to enroll in the study, as well as exclusionary criteria, who you're going to say is not eligible to be in your study. Inclusionary criteria are primarily for targeting participants who are going to be a good match for the outcomes that you're interested in, for the interventions that you're delivering, and for the questions that you're asking. You outline your inclusionary criteria in part so you can report those criteria in your consort statement when you write your paper. But that consort statement is there for a reason. It's there in order for you to lay out very specifically who you wanted to, you know, what the parameters are for the people that you wanted to be in the study. You also, inclusionary criteria also serve the purpose of balancing variance, that is variability, error variance, between the participants in your study, okay? So it diminishes some of that intervariability between participants. That's noise, that's error variance. Okay. So let's say you want to do a study testing a new drug or treatment or intervention for migraines, and you might say that your inclusionary criteria include the type of headaches that somebody has, how long they last, how frequently they have those headaches. And you might say that certain classes of medications are okay for those participants to use. Those are all inclusionary criteria. Anyone who meets those criteria, they have 5 migraines a month at least, of at least 1 day duration, of of certain severity, and the participants only take certain drugs, those people would be eligible for your study if that's the sum total of your inclusionary criteria. Okay? Now, exclusionary criteria serve a different purpose. Exclusionary criteria serve the purpose of providing safety, so you don't include participants who would not be safe to participate in your study. Exclusionary criteria are there to control confounding factors, so things that might travel with the characteristics that you're identifying in certain participants, and that might travel with the outcomes that you're interested in, but you're not interested in those factors, those would be exclusionary. And you can exclude on the basis, you can set exclusionary criteria on the basis of feasibility. If you simply cannot get the participants with the characteristics that you have outlined, that's exclusionary, okay? So an example here, let's say you have a new medication for blood pressure management, right? And so you know that you don't want to include people with heart failure because those people are at high risk for secondary events, and because they tend to also have hypertension frequently, so you're going to exclude them for a safety reason. You might want to exclude people who are diabetic because it's a confounding factor, okay? And you might want to include people who are bedridden because that would be a feasibility issue if your protocol stipulates that participants need to come to your clinical center or your laboratory on a periodic basis. So that might be a feasibility issue. So these are the types of exclusionary criteria that you set. Okay. One thing that people talk about a lot, want to know about, is when do I set these criteria? When do I say who my participants are who I'm going to enroll and who my participants are who I'm going to exclude? When do I do that? You do that very early. You do that before your grant is written. You certainly do that before your IRB papers are submitted. And you absolutely, positively do it before you even look at a potential participant. Okay? You have to do that very early on. And the reason is that and you have to do it very clearly. You know, to have as an exclusionary criteria people that are on medication, you have to be very, very specific. You might say people who are on certain medications, or you might say, and then name them. Or you might say people who are on any prescription medication. Think about over-the-counter medication. Think about herbal medications. You have to be very, very specific. And the reason is severalfold. One is you want to be specific because the people who are going to be running the study are not going to be you, probably. You know, you're going to have a team. And that team, those team members are going to be assessing the suitability for participants to enroll in the study. They need to know exactly what is inclusionary and what is exclusionary. You want it to be consistent across the team, but you also want to make sure that you meet the criteria that you've set out. You also need to be very careful and do this very early because this is a great place for unintentional bias to creep into your study, right? So let's say you're having a really hard time enrolling participants. It's really difficult to get participants in. You have a couple of exclusionary criteria. Someone comes to you, they are perfect, really perfect. One of your exclusionary criteria is you can't enroll smokers. This person smokes 10 cigarettes a day, so not that much. If you're not crystal clear And if you haven't set the exclusionary criteria in advance, you may be inclined to have a little wiggle room in those inclusionary criteria and enroll that participant. And that would be a form of bias that creeps into your study. So you want to prepare for that and make sure you don't have that by setting out those criteria very, very early. So here's the question. Do you ever change your entry criteria? Well, yes, you can. You shouldn't do it very often. In any given study, you shouldn't do it very often at all. And if you have to do it, you better have a really good reason to do it. You better make sure you get IRB approval to do it. And you need to go to your DSMB and get their advice. Changing your entry criteria most typically occurs, or people want to change their entry criteria most typically when they're having feasibility issues, when they can't recruit participants. And that's a dangerous slope to go on, because you can start changing a little bit here, changing a little bit there. Bias starts getting introduced, so you need to be very careful. There are times when, if you seriously cannot enroll participants in the study and your study will fail because you can't get these participants, then you go to your DSMB and ask for advice. Have a clear plan. Have a plan that reduces that bias as much as possible. Write everything down, document it, report it in your final paper. You have to report it in your final paper, in your CONSORT diagram. Okay. Another factor to think about with regard to patient characteristics is context. And context is kind of everything. Context is, all of the things that make up the individual that you're studying in your protocol. So context are things like the personal experiences that participants bring to the study. May be completely irrelevant. It will be completely irrelevant to what you're studying. But it's not irrelevant to the participant, and it's not irrelevant necessarily to the kinds of measures that you take. The social environment, the cultural environment, all of these are contextual factors. And these contextual factors can impact the outcomes that you have. So here's an example. And don't get too caught up in the actual study, even though it's kind of an interesting study. But it's an example of how context can be important. So, and this, by the way, is not an aberrant finding. This is a finding that has been demonstrated several times over. This came from the study of middle-aged women. And the idea in that study was that the researchers were looking at, this is the SWAN study, researchers were looking at the incidence of metabolic syndrome, okay? And as part of that, they took a lot of measures in these middle-aged women, just, background information, a lot of demographic stuff. And almost by mistake, except it wasn't really a mistake because there had been a little suggestion in the literature. These investigators, this was not the primary purpose of the study, but these investigators actually looked at early childhood trauma and looked specifically at abuse. And they found something really interesting. What they found was that women that had had early childhood abuse in middle age were more than 2 times more likely to develop metabolic syndrome than those that did not report early childhood abuse. Again, it's been found in a couple of studies now. That is a contextual issue. Now, it's a little frustrating, right? Because you don't really know what you're supposed to measure if you don't have a little clue. And you don't want to measure too much because the burden on the participants can be too great. But it does tell you that contextual factors are important. Pay attention to them. Think about the measures that you take. Oftentimes those sort of background questionnaire things, we just kind of throw a bunch of standardized questionnaires at people. Think about those questionnaires, what information you want, and what might be particularly relevant, not only for the question that you're asking, but for the participants. participants that you're studying. So different one. Also not an aberrant finding, but when it first came out, it was surprising. And this is a study looking at blood pressure medication and looking at survival over a period of almost, I think it was an average of 5 years, but some went out to almost 8 years. And what they looked at was when blood pressure medication was taken, during the morning or right before bed. And clinically, at the time of this study, which was in 2010, and probably even now, most clinicians, most physicians would say, you know, take your blood pressure medicine first thing in the morning. But what this study and subsequent studies have shown is that if you take, even if you just take one of your blood pressure medications before bed, your chance of event-free survival increases twofold. That's a big finding. Hardly ever find a finding like that. That's a contextual factor, right? Because these researchers were not studying time of medication use. So that's contextual. So think about those things in terms of the questions that you're asking the participants that you're looking at. Access to participants is really critical. You want to think about that early in your planning phase and throughout. Access means having available the participants that you think are most relevant for the study that you want to conduct. And it also means participants who would be willing, who have those characteristics, who would be willing to be in your study. You often need, and this is for not only the reasons of having participant selection factors, but also for other reasons. You want to make sure that you build an interdisciplinary team, and this is really going to help you in terms of access to participants and making a connection with participants who may be able to be in your study. You may, if you have an ambitious study, or if you're studying a rare condition, or if your participants' characteristics that you've targeted are rare and hard to find, you may need to consider multiple sites. And that, again, speaks to the fact that you would likely need an interdisciplinary team. And, you know, I put this in here. Generally, when you're conducting a study, you should not generally include your own patients or practice. There's a dual relationship if you're the practicing physician and the researcher. Let's talk about recruitment and retention. You probably all know that successful recruitment and successful retention is the number one factor that will guarantee success in your clinical trial. And another way of saying that is most clinical trials that fail, that means that they don't get completed, fail because they have not adequately recruited. It is hard. It is really hard. But you have to be able to do it in order to have a successful trial, which means you have to think about it. You have to have a plan for your recruitment. And the things to think about, there are a lot of things to think about, but some of the things besides the characteristic factors that we've talked about are, you want to think about the burden on your population, your patient population. Burden can come in the fact in the types of things that you ask people to do, like fill out 1 million questionnaires. That's burdensome. It can be in the risk associated with either an intervention or a measurement technique that you're implying. That's burdensome. And it also can take the form of burden of actually getting to the site that participants need to get to. So if you're studying participants who are, 100 miles away, and you need them to come to the clinical center, that's a burden. And you need to think about how to lessen that burden if you want to have successful recruitment. Obviously, you think about the health of participants with regard to the burden and the logistics. If you can provide transportation, that often can go a long way in getting participants to actually come to your clinical center. I should tell you, I did years ago, I did a study once of airline pilots. It was the greatest study because they came from all over the country, and they flew in to my lab. It was great. But most participants won't do that. Most of your studies are going to be intent to treat studies, and that means that once you enroll someone into your study, that is, once you randomize someone into your study, they are yours. They stay in your data set. They get analyzed with everything else. That's an intent to treat analysis. You do not get rid of them. Whether they drop out or not, they are yours. So think about that when you set out your criteria and the characteristics that you're going to study when you set out those selection criteria. And as Dr. Kelty says in her video, you want to make sure that your participants, that your sample that you have is inclusionary and appropriately representative. So everyone wants to know, everyone knows it's important to recruit, but everyone wants to know how to do that because it's a struggle. And there are a lot of resources out there, and more now that people are so sort of electronically connected. And I would encourage you to use social marketing strategies and community-based strategies to the extent that it's ethical. It is a great way of getting the word out for the study that you're looking at. The old-fashioned way is to do mailings. It still kind of works. So I wouldn't discount that. And there are the presentations at community settings and various referrals that you get from other clinics. You do want to, when you set out a recruitment plan, you set milestones, right? Monthly milestones for recruitment. And you want to make sure that you put some thought into how you set those milestones. You don't just take your total sample and divide it by the number of months that you're going to be recruiting. You have to think about how much time it's going to take you in the beginning to ramp up your recruitment strategies, how much time you need in the end to start decreasing and following up your participants. So think about those milestones carefully before you set those goals. Oftentimes, it can be very helpful to have a run-in period with participants that you may be wanting to enroll in your study. And this can help you understand whether participants are going to be good fits for your study. This would be before you randomize participants. So you would enroll someone, not randomize them. They're not in either arm. And you would enroll them and then ask them to do some things that would be part of the protocol for both your control and your experimental subjects. And that would be that run-in period. To improve retention, a different issue, that is once you randomize somebody, how do you keep them in your study? You want to manage the burden that participants have, and that simply means think about every single thing that you ask them to do to make sure it's really important to your study, to the success of your study. If it's not, if you can do without it, do without it. It will reduce the burden. You want to make sure that your intervention is as easy as possible to understand and is as short in duration as possible. Very long, complex interventions will really put you at risk for losing participants. To whatever extent you can, optimize their visits. If they're coming to the clinical center anyway for other things, for prescription pickups or regular blood draws, see if you can optimize that opportunity to have that correspond to a visit to your study. If you can figure out what the barriers are, sit down with your participants early on and say, what's going to make it hard for you to be in this study and to stay in this study? What's really tough? And see what they say. If it's parking, find parking stickers. If it's childcare, help them figure that out. Figure out what the barriers are and help to troubleshoot that so that you can maintain that relationship. Of course, incentives and appointment reminders. One thing that can be very useful in terms of retaining your participants is that when you're in that follow-up stage, schedule your follow-up visits very early on. As soon as, at the first follow-up visit, schedule the rest. And then all you have to do is set the reminders for them. That will set their expectations for what they are going to be doing for the rest of the study. So adherence. The best thing I can say about adherence is make sure you measure it, and make sure you measure it well. And if you can do anything to improve it, do it. Adherence is more difficult with very complex interventions, obviously. So again, the simpler your intervention, the better. I kind of like talking about this study. It's not that new, but the data are still valid. This is an interesting study that looked at chronic pain patients, okay? And they asked patients to record their pain levels throughout a 3-week period. And they had a little diary. It was actually a written diary. And there was a microchip embedded in the diary. And so when they opened the diary, the microchip recorded that the diary was opened. And all they were doing is asking people to write down how much pain they had, and write down anything else they wanted to write about the pain that they were experiencing whenever they experienced pain. And then the patients came back to their lab 3 weeks later, and they brought their diaries, and they said, and the investigator said, how adherent were you in writing down your pain in your diary? And 89% said that they entered their data within a 30-minute window. They were highly adherent, right? And remember, they had their diaries with them. So then the investigators looked in the diaries, and they looked on the microchip, which the participants didn't know about, and they found that only 11% of participants actually opened their diaries within that 30-minute window that they were required to. And what this tells you is not that people are trying to lie. What this tells you is that adhering to a protocol is hard. We all have our lives, right? We have a million things that we have to do and a million more things that we should be doing but aren't doing. And that's no different for participants in your study. And when you're asking them to do something that's fairly time, labor intensive, or they have to actually write down stuff, and they have to do it within a certain window, that is burdensome. And so when you ask someone to do something complex and burdensome, you're not going to get good adherence. And that's the lesson from this. So there are strategies to optimize adherence in participants. There's this strategy called motivational interviewing, which you can hire somebody to do for your research participants to get them involved in the study and to get them highly motivated to participate and maintain their participation in the study. One thing that I think works really well is to provide an orientation setting. This would be pre-randomization. So you bring people in, and what you're doing is just giving them information about the study. Be as open, as honest as possible. All questions are possible, and be very open and honest about what the expectations are for being in the study. You will lose people in doing that. You might have 100 people show up to hear about the study, and 75 of them might leave. But they're leaving because either they're not interested or they know that they can't do it because of other things going on in their lives. You do not want to enroll people in your study if they can't complete the study. So it's a really good strategy if you can do it. You can't always do it for all studies, but if you can do it, it's a really good strategy for maximizing adherence and maximizing retention. If you can maintain contact with your participants, that's a really great idea. Participants like it. They will tell you that, oh, I almost forgot about you. So maintaining that contact allows them to remember that they're participating in a study. And this is particularly important for studies that have long-term follow-up periods. And one thing I like, and it really works well, is a way to maintain contact is, send birthday cards. Do calls periodically. How are you doing? Develop a newsletter for your laboratory or for your study in particular and send that out. Just health information. Nothing that's going to interfere with the intervention that you're delivering, but something that you can send out to all arms of your study. It really is a good way to maintain contact. It tells participants that you care about the study and therefore you care about them. And you should care about them. So I have a little bit of time, and I wanted to talk about a study called Enriched. And it's really a way to illustrate some of the points that I've been making with regard to the complexities of enrolling and retaining participants in large studies. Enriched was a study that was conducted several years ago, and Enriched stands for Enhancing Recovery in Coronary Heart Disease Patients. It's a pretty large study, and the rationale for Enriched is here. We know that once people have a heart attack, if they become depressed or were depressed when they had the heart attack, their survival after the heart attack is lower than for people who are not depressed. We know that. It's been demonstrated in lots and lots of studies. So Enriched asked the question, well, what if we did something about the depression? Would that help with the risk for a second heart attack? Pretty simple question, really complex though. So the purpose was to test the hypothesis that if you treat depression and, by the way, low social support, because they tend to go hand in hand, very soon after a heart attack, will you reduce myocardial deaths, cardiac deaths, and non-fatal recurrent infarctions, that is second heart attacks. That was the purpose of Enriched. Okay, so you already know that they want to get participants very soon after a heart attack. They're going to get vulnerable participants, right, because they've already had a heart attack, and they want to get them quickly after that heart attack. And they're going to screen them on what? They're going to screen them on depression and social support, right? Okay. So in Enriched, almost 2,500 post-MI patients that were depressed or had low social support, and many had both, were enrolled, and they were randomized into either a usual care arm or a psychosocial arm. And the psychosocial arm intervention was really focused on the social support and the depression. And it was based on cognitive behavioral therapy techniques. Usual care was usual care for any post-MI patient. And these participants were followed for 3.4 years after they were given the intervention. And the primary endpoint was death or non-fatal recurrence. And it was an intent to treat analysis. Which means that everyone who was randomized was included in the final analysis. Which is the way you want to do it. So there were some inclusion criteria. They had to be identified within 28 days of having a heart attack. They had to have enzymatic data indicating that they had had a heart attack. And they had to be depressed and or be low in social support. And there are good ways to measure those two things. Now, here's part of what I want you to see. So there's not a lot of inclusionary criteria, and there are very few exclusionary criteria. And a lot of people have heart attacks, right? 500,000 people in the United States have a heart attack every year. That's a lot. So in Enriched, almost 34,000 people were screened. And not all of them met criteria for having had a heart attack, but most of them did. So a little over 32,000 met the criteria. They had had a heart attack. And then they needed to be either depressed or have low social support or be medically eligible. That is, they needed to be stable. And most of them were excluded based on that basis. So in the end, fewer than 2,500 participants were randomized. So they started with 34,000, and they got 2,481 participants. That's a lot of people to screen, a whole lot of people. And this was not a very stringent inclusionary and exclusionary criteria.